Welcome to the new video on bronchiectasis. It's one of the very common cases that you see in your wards. At the same time, it's always almost due to some underlying disorder. So you'll be commonly seeing in COPD patients, sometimes in TB patients also. Very common one, at least in India. So bronchiectasis, first of all, as we are going to ask in all the videos, ask the question why and what. So if you ask what is bronchiectasis, the definition wise, it is a permanent and irreversible dilatation of the medium-sized bronchi. Irreversible dilatation of medium-sized bronchi. Typically, this should not be called as bronchi. Instead, by modern definition, it should be called as bronchioles, especially the proximal bronchioles. But let us stick with the tradition. The medium-sized bronchi is also referred to as subsegmental bronchus, typically the 4th or 5th generation bronchus. So that's what is going to be affected. Clear? And bronchiectasis is typically a suppurative lung disease, which means it's going to form pus and there should be a lot of cough with expectorations. That's what you expect in a suppurative lung disease. And next, you have to know that bronchiectasis is almost always a secondary disorder, which means there should be some underlying cause in almost 99 to 100% of the times. It doesn't come as a primary disorder except in a few congenital conditions. Apart from that, it's almost always a secondary disorder to some underlying problem. Pathophysiology wise, bronchiectasis has two important pathological processes, of both which should be present in the patient to get the bronchiectasis. First, there should be a local infection or at least an inflammation should be there, and this should be coupled with your reduced clearance of airway secretions. Reduced clearance of airway secretions. So these are the two pathological processes that should be there, and it's a must to produce a bronchiectasis. Infection, inflammation, infection can be caused by a variety of agents including tuberculosis, any other pneumonia, so viral infection, lot of infections you can tell. At the same time, reduced clearance of secretions may be due to your airway obstruction, or it could be due to damage to the cilia. Damage to the cilia. Damage to cilia can happen after viral infection. Sometimes in children especially, I told you, some phenomenon called a ciliocytophthoria. We discussed already about this fact where after viral infection, you're going to get this ciliary damage and shedding of the bronchial epithelial cells. Or it could be due to some ciliary abnormalities congenitally also, like Cartagena syndrome, immotile cilia syndrome, a lot of things are there. So whatever may be the case, so these two primary things, number 1 and number 2, so both should be there to develop bronchiectasis. So with this basic understanding, let us move to an image where you can see a normal airway on the one side, on the left top, and you can see these are the types of bronchiectasis. First one is the cylindrical types of bronchiectasis. These are also referred to as Reed's types of bronchiectasis, and it is based on bronchogram. This name Reed you would have already encountered in COPD, chronic bronchitis part, where I told you something called a Reed index. You can go back and read once again. So Reed came back again. So he's the one who classified this, but this is completely outdated. This is not at all useful anymore. But anyways, so cylindrical type, there is a uniform dilatation of the airways. There is no beaded or cystic appearance. It's a uniform, just dilatation, like a fusiform dilatation you can imagine. So this is what we call as cylindrical type, and it is supposed to be the most common one. Then you have varicose type, where you have typically this beaded kind of appearance. So this is varicose, where you're going to have a beaded kind of appearance. Typically, this is the most rarest form which you will face. And finally, you have cystic, like clusters of grapes will be there. So these are called as cystic appearance or cluster of grapes appearance. And this is supposed to be the most severe form, second most common form, but supposed to be the most severest form. Then let us move on to the etiology of bronchiectasis. Etiology of bronchiectasis wise, number 1, lot of pulmonary infections can cause bronchiectasis. Typically, you can get in bacterial, viral, or even a fungal infection, especially after a severe or a chronic infection. When you get a very severe infection or after a chronic infection, after that you might end up with bronchiectasis. It's a very common entity. In fact, these pulmonary infections are the most common reason for bronchiectasis in India. And the most common pulmonary infection that causes bronchiectasis in India is the tuberculosis. Number one. Number two, reduced clearance of secretions, or you can get in mucus whenever this mucus is impacted and mucus is plugged. We call it as mucus plugging. So what are the conditions? Whenever I say mucus plugging, because if you have watched my previous videos, the first thing you have to tell it's an allergic bronchopulmonary aspergillosis. Even though it's not that common, but still, that's what I have commented a lot about this mucus plugging, where in X-ray also you see this sign called finger in glove appearance. So all these things we have seen in ABPA, Aspergillus chapter itself. So number one is ABPA. Number two is cystic fibrosis, obviously. Number three is a disease called a primary ciliary dyskinesia, where the movement of the cilia will be weak, because of that your clearance of the secretions will be poor. Number three. So you can tell bronchial obstruction or bronchial narrowing. You can tell in any way, bronchial obstruction or bronchial narrowing. Typically, it can happen in COPD, aspiration, where aspirated foreign body can result in obstruction. COPD is a natural disease of obstruction, typically with a foreign body. And next is the tumors. Tumors can compress in the bronchus and they can cause an obstruction. So third is the bronchial obstruction. Fourth is conditions causing immunodeficiency. A lot of conditions can cause immunodeficiency, like HIV, one of the very, very common and acquired immunodeficiencies. Then you have congenital immunodeficiencies like common variable immunodeficiency. We have discussed this already in hematology, CVID. Or you can also get in a lot of conditions, congenital as well as acquired, that causes reduced immunoglobulin production, referred to as hypogamma globulinemia. Apart from that, any chronic inflammatory disorders of the lung. Chronic inflammatory disorders of the lung, like rheumatoid arthritis, Crohn's disease, Sjogren syndrome. Clear? All these things can cause fibrosis, and because of fibrosis, you will get bronchiectasis. Why? Because of fibrosis, you will get bronchiectasis. Fibrosis of the parenchyma, I'm not telling fibrosis of the bronchus, there will be fibrosis of the parenchyma. Because the parenchyma is getting fibrosed, they shrink, and the airways, are not really affected in this fibrosis of the lung in initial stages at least. So what will happen is, since the fibrotic parenchyma shrinks, the airways that are present embedded within the parenchyma will be pulled and they will start dilating. That is due to fibrosis and shrinking of the other parts of the lung. The caliber of the airway starts increasing. For example, if you have the airways here, and if you take, this is the lung parenchyma, the surrounding. So when the lung parenchyma starts shrinking around the airways, the caliber of the airways tends to increase. That is because of the surrounding fibrosis of the lung parenchyma. This kind of dilatation of the the medium-sized bronchi, because of the fibrosis pulling the walls of the bronchus apart, is what we refer to as a traction bronchiectasis. So this type of traction bronchiectasis happens very commonly with fibrosing conditions. Clear? Apart from that, you have a lot of congenital conditions that can cause bronchiectasis, but we'll discuss in a separate area in the same section. Clear? So these are the reasons pulmonary infections tend to be the most common, then reduced clearance and bronchial obstruction, immunodeficiency, chronic inflammatory disease. At the same time, you have a lot of congenital conditions also that can cause bronchiectasis. Then, we'll move to the clinical features. So what are going to be the clinical features? The most common symptom in the patient will be a chronic productive cough. Chronic productive cough, that will be the most common symptom in this particular patient. And the cough that is going to be produced will be very, very copious, which means it's going to be produced in too much amounts, and typically mucopurulent, because it's a suppurative lung disorder. And they tend to have a postural variation, which means they vary, they have variation with posture. That means when they lie down, actually they cough more. And again, depends on which segment is it's affected. But anyway, most of the patients will complain when they lie down, the cough and expectoration will increase because of the gravity related effects. Clear? So that's why I told you, if you want to comment on that, you can tell the cough and expectoration will increase on dependent postures like typically lying down in supine posture or lateral decubitus. A particular lateral decubitus depending on which lung is involved. So this is a very important thing. Clear? One of the small important exceptions where you don't get this productive cough is a place where because of fibrosis and traction bronchiectasis, if you get bronchiectasis, you won't get productive cough, because here the problem is not really suppression, or here the problem in fibrosis is not infection or obstruction of the bronchus. It is the fibrous that pulling the walls of the bronchus apart. So typically there is no need for getting a productive cough, because there is no sputum production at all here. So typically you will have a dry cough only in fibrosis, but apart from that, in all the other causes you will have a chronic productive cough, which is going to be the most common clinical feature. Apart from that, they might have a low-grade fever and weight loss, because there is a chronic infection going on in that area. That's why low-grade fever, weight loss, and they can also develop hemoptysis. Clear? Remember, they will ask you why this hemoptysis is happening in bronchiectasis. Remember, it is not due to rupture of the pulmonary or bronchial vessels. It is due to rupture of the airway wall vessels itself. The airway wall is dilated here. Because of dilation, the wall dilatation will create a traction in these small micro vessels, and they tend to rupture. So, and that is the reason for hemoptysis, not due to breakage of the pulmonary vessels. That will result in usually very severe hemoptysis. But here, hemoptysis usually in the early stage it will be mild, and that is due to breakage of the vessels that are present in the airways itself. That is getting dilated because the traction effect they break. And typically it is seen in approximately 40 to 70% of the cases, which means it's not that rare also. You get hemoptysis often in a bronchiectasis. Then what will be the signs? The most important signs will be a coarse, leathery, inspiratory crackles, typically a mid-inspiratory crackle. Coarse, leathery, mid-inspiratory crackle. Very, very, very important. Clear? End inspiratory crackles generally tend to be fine, and they will be usually associated with the fibrosis or ILD, like idiopathic pulmonary fibrosis. But coarse, leathery, early to mid inspiratory crackles is very, very typical of a bronchiectasis. Clear? So this is a very important point again. Then you might have a clubbing in the patient, but this generally happens after years. It's not very common. Then you might also get a anemia. Anemia will typically be due to iron deficiency anemia or even anemia of chronic disease. But still, the main reason for anemia is to small amounts of blood that will be lost every time they cough up the sputum. So it could be either iron deficiency or maybe due to anemia of chronic disease also. Clear? Then this bronchiectasis patients are also prone for exacerbations. The exacerbations that you get in this bronchiectasis patients and the organisms that you see during exacerbations are a little bit similar to what you see in COPD. For example, the most common organism that is associated with the exacerbation in bronchiectasis patient is a H. influenza. And the organisms are also very, very similar to the COPD exacerbation. How will you diagnose? There will be increased sputum production compared to the baseline. At the same time, patient will have a new onset of fever. A new fever with increased sputum production compared to the baseline sputum production of the patient, because the baseline sputum production of the patient himself will know what is his baseline sputum production, and if it increases, definitely he will be aware of that. And coupled with that, if you have a new fever, that diagnoses the exacerbation in a bronchiectasis patient. So that's why it's important. Then we'll move on to the complications of bronchiectasis. What are all going to be the complications? Complication wise, you can see many things. Number one, typically some organism colonization with certain bacteria. Very commonly, they get colonized with Pseudomonas aeruginosa. Pseudomonas colony is the most important. Remember, and this Pseudomonas colony in bronchiectasis patient is not a very good sign, because they're very difficult to eradicate. Whatever you do, they tend to persist there in the local area, and the colony keeps growing again and again. Maybe transiently it will respond to your antibiotics, but again, the cultures will become positive, the colonies will be positive. It's very difficult to eradicate the colonization. Or in very severe cases, it can be Burkholderia capacia also. You can have Burkholderia capacia complex, but this Burkholderia capacia complex is again very, very difficult to eradicate, and it's a highly resistant organism. So these organisms, if it's present in the colony in the lung itself, is a very poor prognostic state, which means they don't do really well. Number 2. Second complication is a massive hemoptysis, where there can be really a rupture of some major vessel. Because of that, they can result in a hemoptysis. Number 3, they can go, typically your bronchiectasis is classified under obstructive lung disease. So because of that, they can go for pulmonary hypertension and carpulmonale. That is right heart failure also. Again, infections are very common, which can progress to produce empyema and lung abscess. Absolutely possible. Finally, bronchiectasis is one condition where you can get amyloidosis. Typically, amyloid that will be deposited is the amyloid of chronic inflammation, that is serum amyloid A. That's why you get the AA amyloid deposition. Typical phase of AA amyloidosis can develop. So if it's a long-standing, untreated bronchiectasis, if it's the case. Then diagnosis-wise, how we are going to do a diagnosis? Diagnosis, first investigation we generally do is the chest X-ray. In chest X-ray, typically you are going to see this bronchial dilatation. You can see them in chest X-ray. I will show you bronchial dilatation, and they will be appearing as tram tracks because of the bronchial wall thickening. Normally, if a bronchus is like this, so here you will be getting a dilatation of the bronchus, and you will be getting thickening of the bronchus also. Thickening of the bronchial wall. So this is what we refer to as a tram track appearance, which you will be seeing in the X-ray, and it will be usually filled with suppurative material. So this you can see in the X-ray. That's what we call a tram track appearance. Or you can alternately do a CT. Remember, HRCT is the best investigation and considered to be the investigation of choice for a patient with bronchiectasis. What are you going to see in HRCT? We have already discussed that fact that we are going to see something called a bronchial and arterial diameter and the ratio of it. Let us consider this to be the bronchus, and let us see this is the artery. Normally, I told you, when you take a bronchus to arterial diameter, it should be around 0.65 to 7. So this should be the ratio, which means the bronchus should be smaller compared to that of the artery. But if the ratio becomes more than 1, suppose you have a bronchus that is hugely dilated and you have an artery like this. So if the bronchus to artery ratio becomes more than 1, and that is the CT definition of bronchiectasis. And this will be seen in the subsegmental bronchi. If you ask the radiologist, they will look for bronchiectasis in the subsegmental bronchus only. Typically in the proximal bronchioles, you can call like that also. So this is the definition of bronchiectasis in CT. It's a very, very easy thing to pick up in the CT and a very sensitive thing. That's why HRCT is the gold standard investigation of choice to find out bronchiectasis. Suppose the ratio becomes more than 1.5, which means it's too big. So what I have shown here is definitely more than 1.5. That forms something called a signet ring appearance, or otherwise referred to as a Jewell-on ring appearance. Jewell-on ring appearance. So especially when the ratio becomes more than 1.5, you're going to call it as a signet ring appearance or a Jewell-on ring appearance. Clear? So, and the same tram tracking also you can see in the CT, which means you can see a bronchus whose wall will be thickened and also will be dilated, and there will be some secretions along with it. This is what we call as a typical tram tracking appearance. What you saw in the chest X-ray, you can see in the CT also. And certain times the distribution of the dilated bronchus will help you in picking up what could be the probable diagnosis as well. So let us see that. So there is a central or a perihilar distribution. This is also referred to as a proximal bronchiectasis. Then your bronchiectasis can be typically distributed in the upper lobe, or it can be in the lower lobe, or it can be in the middle lobe also. Remember, bronchiectasis in the lower lobe is the most common form. And this is the most common area where bronchiectasis comes, that is on the lower lobe. So let us see some of the causes of each and everything. So central perihilar or proximal bronchiectasis, if I tell you this word, if you have seen the previous video, you should answer the first thing must be ABPA, that is allergic bronchopulmonary aspergillosis. And second thing, that also I mentioned in your aspergillosis video, where I told you it's cystic fibrosis. These are the two things immediately that should come into your mind the moment they call a central or a proximal bronchiectasis. Third, there is another entity called a Mounier-Kuhn syndrome. That's called a congenital tracheomegaly. So I think my spelling will be correct. Mounier-Kuhn syndrome. Basically, I'm very poor in spellings, but anyways, Mounier-Kuhn syndrome, congenital tracheomegaly. And you have Williams-Campbell syndrome, both of which we are going to discuss in some time. Williams-Campbell syndrome. And what are the conditions that cause upper lobe bronchiectasis? Typically, once again in ABP and cystic fibrosis. The conditions which are going to cause proximal bronchiectasis only will cause upper lobe bronchiectasis also, most often. What are the conditions that produces lower lobe bronchiectasis? Most commonly it is due to post-infectious bronchiectasis, which is supposed to be the most common reason for getting a bronchitis. That's why lower lobe is most common. You can equate it that way. Aspiration will cause lower lobe bronchiectasis only. And your immunodeficiency syndromes like hypogammaglobulinemia, you have HIV, any immunodeficiency syndrome because of low antibody production, low immunoglobulin production, you are going to result in lower lobe bronchiectasis very commonly. And in primary ciliary dyskinesias, like cartaginous syndrome. So, in these conditions also you are going to get lower lobe bronchiectasis only. What about the middle lobe bronchiectasis? Middle lobe is something special and it's an exam favorite. Clear? So, this middle lobe bronchiectasis can happen in two classic cases. One is called a MAC infection. That's called Mycobacterium avium complex infection. This MAC infection causing a right middle lobe bronchiectasis is also referred to as Lady-Windermere disease or Lady-Windermere syndrome. So usually you will see that bronchiectasis will happen in an immunosuppressed patient very commonly, but this Lady-Windermere syndrome will happen in an immunocompetent women or immunocompetent people. Very commonly these people will be elderly patients. At the same time, they will be someone who will be chronically suppressing their own cough. Chronic suppression of cough, which means they voluntarily suppress the cough production. Even if cough comes, they don't allow it to come, they will voluntarily suppress. So these kind of patients are the ones who are more prone. And typically majority of them will be female. This is a typical case description in your exam will be. And you are going to get bronchiectasis of the right middle lobe and lingular lobe. Remember, lingula is something that is equivalent to the right middle lobe. In the left side, you don't have a middle lobe, instead you have a lingula. Even though it belongs to the upper lobe by anatomy, but lingula is something considered as a middle lobe of the left. But there is no middle lobe in the left. Please be very sure about that. So these are the features of Lady-Windermere syndrome or Lady-Windermere disease. Number 2, you have right middle lobe syndrome. Sometimes it can happen in children, that is due to right middle lobe collapse, so which can result in bronchiectasis. But remember, you will have no obvious obstruction. Right middle lobe will collapse in certain children, but there will be no obvious obstruction. Majority of the times we see collapse that is usually associated with an obstruction, bronchial obstruction. But here there is no obstruction, plus the patient will have bronchiectasis also. So this combination of a right middle lobe collapse and you have no reason for the collapse, at the same time you have associated bronchiectasis is what we refer to as right middle lobe syndrome. And apart from that, as a special one, we have another thing called a focal or a localized bronchiectasis. Localized or a focal bronchiectasis. Usually this will be caused by a foreign body that is aspirated, which will cause bronchiectasis only in that local area where it is obstructed. Similarly, a tumor obstructing a bronchus. So this foreign body or a tumor obstructing a bronchus will cause bronchiectasis only in that area which is affected by this obstruction. Those bronchopulmonary segments which are affected by this obstruction, those only will go for bronchiectasis. So this is what we refer to as a local or focal bronchiectasis. So these are the important CT types or X-ray types, you can call whatever. So these are the localizations of bronchiectasis which might help you in understanding the stuff by your imaging techniques. So in that, the most important will be the central or perihilar, of which ABP and cystic fibrosis is very important. And the middle lobe, especially the Lady-Windermere syndrome, they will ask very commonly. And lower lobe is the most commonly involved, and that is also a very important point. Apart from this, not much is there in this particular table. Then another investigation, if you see a spirometry, what is the pattern you're going to see? It may vary depending on what is the underlying disease, but very commonly you will see a obstructive lung disease pattern. That FeO1 by FVC ratio will be less than 0.7 and FVC will be relatively normal, and this will typically resemble a obstructive lung disease pattern, and that is the reason why bronchiectasis is actually placed under one of the obstructive lung diseases. Okay, how will you manage now treatment wise? Treatment, you are literally going to manage by conservative measures. The most important of those is the physiotherapy. The drainage of the secretions is very, very important, because if you don't drain those secretions, they accumulate in the place and they're going to cause more and more dilatation of the bronchus. At the same time, they are also going to result in repeated infections, because the secretions itself is infectious. So you have to drain them somehow, you have to take it out somehow. So the first thing, we can call it as a conventional physiotherapy, chest physiotherapy, and the second one we can call it as a device physiotherapy. Conventional physiotherapy, the first one, we have a postural drainage. Depending on which bronchopulmonary segment is affected and which lobe is affected, you can make the patient lie down in that particular posture so that the secretions will come out. So that is what we refer to as postural drainage. And second, you can do chest percussion. If you go to ICU and if you order chest physiotherapy, you can do a lot of physiotherapists coming and doing this. This is called the chest percussion. Typically, they will do by cupping and clapping method. And this is a method that is involved, cupping and clapping method. They do like this, cupping and clapping method. You can see in the most of the inpatient wards, when you order for a chest physiotherapy, the physiotherapist comes and does this. Chest vibrations, very commonly done by physiotherapists. At the same time, you have a last one, something called assisted coughing and huffing. This is also one technique. All these things are conventional techniques, but very modern techniques, the device-based techniques have also come. That's called a PEP device. That's called a positive expiratory pressure device. So which cause a positive pressure during expiration so that the secretions come out. So that's called a positive expiratory pressure device. Then you have high frequency chest wall oscillation device. So this is also very important, an exam question. High frequency chest wall oscillation device. Apart from that, through brands are there. One has an acapella device and you have a flutter device. So, but most important for exams will be this high frequency chest wall oscillation device, which is one of the important things for device therapy, for removal of this secretions through physiotherapy. Next, we are going to see on the role of antibiotics. Antibiotics have very little role in bronchiectasis, but typically used in times of acute exacerbation. I told you the most common organism that you will encounter during acute exacerbation is Haemophilus influenza, and the organisms are very similar to what you encounter in COPD. And that's why we typically prefer macrolides. And is there any role for long-term azithromycin therapy? That is a macrolide. Azithromycin is a macrolide. Long-term azithromycin therapy. Yes, typically the guidelines tell if there are more than 2 exacerbations per year, you can prefer this long-term or chronic azithromycin suppression therapy. Remember, this more than 2 exacerbations per year is usually associated with the high risk. Even bronchiectasis, even in bronchial asthma, this 2 or more exacerbations per year is definitely a high risk patient. That's the reason why we prefer using this long-term azithromycin. But again, some people do condemn this use because it will result in emergence of drug-resistant strains of bacteria once you stop the azithromycin therapy. So again, it has its own pros and cons. And one more important fact is you have to rule out non-tuberculous mycobacterial infections before starting with azithromycin, because these macrolides form one of the very important component of treatment to treat your MAC complex and non-tuberculous mycobacterial infections. So if you are going to use azithromycin, be very sure that the patient is not having any NTM infections. Clear? Because when you suspect this MAC infection, especially whenever there is a right middle lobe and left lingular lobe bronchiectasis, in those conditions you can suspect Mycobacterium avium complex. Please rule out before starting long-term azithromycin. Then finally, you have some congenital conditions that cause bronchiectasis, which I have promised to tell you at the last. So congenital conditions that cause bronchiectasis, I can put 4 conditions. One is called William-Campbell syndrome. William-Campbell syndrome. Second one, your characteristic Mounier-Kuhn syndrome. And third one, you have primary ciliary dyskinesia, otherwise referred to as immotile cilia syndrome. Immotile cilia syndrome. And the fourth one, you have a lot of other syndromes like Young syndrome and yellow nail syndrome. Let us see one by one. What is the problem in William-Campbell syndrome? Point number 1, it's due to the deficiency of cartilage in 4th to 6th generation of subsegmental bronchus. So you can tell deficiency of cartilage in 4th to 6th generation airways. Typically we call 4th to 10th generation as subsegmental bronchus, but modern terminology tells they are proximal bronchioles. So this is the problem in case of a William-Campbell syndrome. It's a congenital deficiency. Number 2, they will have a symmetric, at the same time bilateral and cystic bronchiectasis. And very important point is the fact that trachea and main stem bronchus, that is generation 0, generation 1 and up to even generation number 3, that is the segmental bronchus will be preserved. The most important thing is the trachea and the main stem bronchus is preserved. Why this is important? Because this is the main thing that is used to differentiate with the Mounier-Kuhn syndrome, where we call it as something called a congenital tracheomegaly. What happens in Mounier-Kuhn syndrome? It is due to deficiency of elastic fibers, not cartilage. Elastic fibers and smooth muscles, not cartilage. Clear? William-Campbell is due to cartilage. How do you? I used to remember this C stands for cartilage because William-Campbell is for cartilage. At the same time, this Mounier-Kuhn, M stands for smooth muscle. So that's how I used to remember. So it's a problem with the elastic fibers and smooth muscles, especially in the trachea and the main stem bronchus. Why I told you this fact, you can understand now. Here, the main thing that is preserved is the trachea and the main bronchus. Here, the main thing that is affected is the trachea and the main bronchus. The trachea will go for dilatation. That's why you have this. The name came, that is called congenital tracheomegaly. Diagnosis is going to be based on CT appearance of your trachea, where the tracheal diameter will be more than 3 cm. At the same time, patient will have a bronchiectasis. Remember, in Mounier-Kuhn syndrome and William-Campbell syndrome, the bronchiectasis is going to be proximal or otherwise called as central bronchiectasis. I think we would have seen that in your classification of location of bronchiectasis in CT. I've told you already all these things. Then let us see 2 other syndromes. Then come back to the primary ciliary dyskinesia. What are the 2 other important syndromes? One is the Young syndrome. Young syndrome is a triad. I'm going to tell 3 triads from now on, which are very important for your exams. Young syndrome is typically a triad of obstructive azoospermia, which means they will have male infertility. At the same time, they tend to have sinusitis, and next, they have bronchiectasis. So this is the characteristic triad of Young syndrome. Remember, seeing obstructive azoospermia and bronchiectasis, the most important DD is cystic fibrosis. Even though sinusitis and cystic fibrosis is a little not so prominent, but you have to be very sure that cystic fibrosis is a DD for Young syndrome. How can you rule out cystic fibrosis? You can rule out cystic fibrosis by doing some important test called a sweat chloride test that will be typically negative in Young syndrome, whereas it will be positive in cystic fibrosis patients. And second, they will not have a family history. You will not have any family history at all. So cystic fibrosis patients definitely will have a family history. So where Young syndrome patients will not have family history. It's not a very hereditary disorder, but it's a congenital disorder. There's a lot of difference between hereditary and a congenital disorder. Then You can have another syndrome called yellow nail syndrome. Yellow nail syndrome is again another triad. We are going to see three things. One is going to be pleural effusion, and second is going to be lymphedema, and third, you're going to have yellow nails. And remember, bronchiectasis is not a part of the triad, but still it's a very common feature of yellow nail syndrome. Clear? So third triad I'm going to discuss under primary ciliary dyskinesia, which is otherwise referred to as something called immotile cilia syndrome. One of the subtype of this immotile cilia syndrome or primary ciliary dyskinesia we refer to as something called a Carter-Jenner syndrome. Carter-Jenner syndrome, you know what is a triad? Triad is situs inversus, where there is going to be malposition of your organs, especially the right-sided organs will be on the left and left-sided organs will be on the right. Typical example is the liver and the spleen, and probably the heart, where there will be dextrocardia. That's what we refer to as situs inversus. And next they are going to have sinusitis and they are going to have bronchiectasis, which means it's very similar to Young syndrome, but just remove your obstructive azoospermia and put situs inversus in place of it. That's all. You're going to get Carter-Jenner syndrome, immotile cilia syndrome. Clear? So, typically, patients will have Carter-Jenner syndrome features, that is situs inversus, sinusitis and bronchiectasis. At the same time, there is a lot of chance that the patient might have male infertility. At the same time, they might also have ectopic pregnancy. Why this happens? Because the sperm movement is also based on the ciliary movement, ciliary beat only. Similarly, your ectopic pregnancy will happen because the movement of the ovum towards the uterus from the fallopian tube is also based on the ciliary beat only. So if these are all defective, the sperm cannot come out, which will result in azoospermia. At the same time, your ovum cannot move into the uterus, resulting in a ectopic pregnancy or a tubal pregnancy, which can happen in the fallopian tubes itself. So these are all the two important associated things. So let us see how the cilia will look like. So for that, we can see an image, because structure of the cilia is very important for exams. In this, you can see here. So this is the cilia you're going to have. So first one, these are the microtubule doublets. You can see whatever I'm drawing here. These are all the microtubular doublets. So how much I'm drawing is totally 9 peripheral. I'm not telling 9. You have 9 peripheral microtubular doublets and 1 central microtubular doublet. 1 central microtubular doublet, which means total number of microtubular doublets you are having in a cilia is 10. So 9 peripheral, 1 central microtubular doublet. These are microtubules. And the peripheral we are going to call as A and B, and the central we are going to call as C1 and C2. And they generally tend to have 2 dynenums. This pink color which I am drawing are the dynenums, or the red arrows which is mentioning here. These are the dynenums. This one is the outer dynenum and this one is the inner dynenum. And typically this dynenums is going to originate from the A tubule only. Clear? Very, very important point. Dynenums originate from the A tubule. And second one, you have this connection between this B tubules. Usually there will be connection with this B tubules in general. This connection with this B tubules is what we refer to as Nexin links. Nexin links, connection with the B tubules. Then you can also see there is something called a radial spoke that is coming from the periphery towards the center. This radial spokes are going to originate from the A tubules again. Clear? Radial spokes are going to originate from the A tubule, which means the problem can be in the microtubules. The problem in the cilia can be due to problem in the, dynenum. Problem in the cilia can be due to the radial spokes, or problem in the cilia may be due to the Nexin links also. So you have 10 microtubular doublets, 9 in the periphery and 1 in the center, which is connected by periphery. It's connected through Nexin links, through BB connections. And from A, you have 2 things. One is the radial spoke towards the center, and outward you have 2 dynenums, one in the outer and second is the inner dynenum, which starts from the A tubule only. So this is the generalized structure of the cilia. But very commonly, the defect due to this primary ciliary dyskinesia, all these things will be on the dyneema only. Very commonly, the defect will be on the dyneema. This one. So that is only will cause the abnormal ciliary movement or ciliary dysfunction. And this is an electron micrograph image of the same. You can see the doublets, peripheral doublets here. At the same time, you can see the central doublet. This is the radial spoke, and these are the dyneems. You can see. You cannot see the Nexin link so clearly, but a lot of structures you can see here very clearly. And where this cilia is present, typically they are present up to the, let us see some of the facts about this ciliary function. First of all, the cilia is going to be present until the 16th generation. Number 2, they always beat in the same plane. The plane which is favorable to push the substances outside the respiratory tract into the atmosphere. They always beat in the same plane in the entire length of the respiratory tract. They beat synchronously in the same plane. Number 3, the beat frequency is approximately 1000 to 1500 per minute. That is the beat frequency. Even though the more distal you go, the beat frequency may become a little bit less, but 1000 to 1500 per minute is the exact beat frequency. Then there is something called a mucociliary transport rate. This is something very common question during our times. The transport rate of the substance that is deposited in the respiratory tract towards the atmosphere. That is going to happen at a rate of 20 to 30 millimeter per minute. 20 to 30 millimeter per minute, or you can tell 2 to 3 centimeter per minute also. This is the mucociliary transport rate. Then you have certain screening tests for suspected cases of primary ciliary dyskinesia. The most important, the first screening test is Sakharin test. It's a very, very common test they used to ask in our entrances when we were studying. Sakharin test, where we used to keep a bead of small, very small Sakharin molecule in the anterior end of the inferior turbinate in the nose. By natural ciliary movement, they should be pushed towards the nasopharynx. So this Sakharin molecule, by natural movement, if they are pushed towards the nasopharynx, and you should feel the sweetness in a short period of time. That is typically the sweetness of the Sakharin molecule in the nasopharynx should be felt within 10 to 20 minutes. If it's taking more than 20 to 30 minutes, it's likely to be a ciliary dysfunction. So this test is poorly reproducible because, and many false positives as well as false negatives are there, because the movement can be accentuated by just body movement itself sometimes. So it's very difficult to tell that this is the reason for the late movement or early movement. So be very careful. That's why we devised a new test called a nasal nitric oxide test, where the nasal nitric oxide levels will be low in a primary ciliary dyskinesia patient, and it's supposed to be the best screening test and very, very highly sensitive test for diagnosing this primary ciliary dyskinesia. Very important point. So confirmatory tests are there, which I didn't tell you. Confirmatory tests for this primary ciliary dyskinesia is going to be transmission electron microscopy, where you can see the actual ciliary structure, ultrastructure, and you can find out where is the problem. And second one, you have genetic analysis also, which will also tell, depending on the genetic defect, whether it's really a primary ciliary dyskinesia or not. So these are some of the interesting stats and facts about your primary ciliary dyskinesia. With this, we can move on to some images, where you can see, this is the first image I'm going to see. This is a typical bronchiectasis, the classic cylindrical type of bronchiectasis that you see. That's a very common form. You can see this typical tram tracking. These are the, the subsegmental bronchi that are going for dilatation, and the walls also you can see it is typically thickened walls, and the bronchus is also dilated. So this is typical example, and you can see one more example here also. You can see some bronchiectatic areas. And this is a CT image of the same patient, where you can see multiple tram tracking again. You can see dilated bronchus and tram tracking. These are all dilated bronchus, subsegmental bronchus. And this is the classic example of a signet ring appearance, where this is the artery and this is the bronchus, where the bronchial arterial ratio is more than 1 year. It's dilated. Then you can see some congenital disorders. This is a typical example of a Williams-Campbell syndrome. The first thing I will see to differentiate between Williams-Campbell and Mounier-Kuhn is the tracheal size. Here the trachea is normal. I'll put in a different color. Trachea is normal here, and you can also see trachea is normal here, and the main stem bronchus are normal, but you are seeing typically a lot of reticular densities. These are reticular densities in the lower zone. And when you take a CT, you can see a lot of densities are due to this bronchiectatic, typically the cystic bronchiectasis. That is what you are seeing here. So this is typically present in the central or the hilar zone. So this is what you're going to get in William Campbell syndrome, that's central bronchiectasis. And all these things confirm, all these cut sections confirm, very likely you're having a central bronchiectasis. Clear? And these are type of cystic bronchiectasis and central bronchiectasis congenitally without tracheal involvement. You are going to call it as William Campbell syndrome. And this is an example of a Mounier-Kuhn syndrome. Mounier-Kuhn syndrome, where the most important thing that's going to happen is the tracheomegaly. And the main stem bronchus will be dilated. You can see this is the typical and severe tracheomegaly, and here also you can see the tracheomegaly is there. And you can also see the tracheal diameter here is more than 3 centimeter. That's why this Mounier-Kuhn syndrome is also referred to as congenital tracheomegaly. Clear? So these are some of the important congenital syndromes you have to know. Remember, whenever you are thinking about bronchiectasis in exam, so let us give a small flowchart at the end as a boost. Bronchiectasis in exam, you have congenital types of bronchiectasis or acquired types of bronchiectasis, where acquired is the most common and it's very easy to diagnose. Usually, probably they will be due to TB, COPD, ILD. Remember, ILD will not cause sputum, instead it will cause traction bronchiectasis, which is going to have a dry cough only. But very common in India will be TB only, some infection or a foreign body. Foreign body will cause a localized bronchiectasis. Congenital, see for other additional features like azoospermia, situs inversus, or yellow nails. Anything is there in the exam, or pleural effusions. Anything is there in the exam, along with bronchiectasis, if it's congenital. Suppose if yes means your diagnosis must be either Young syndrome or primary ciliary dyskinesia or yellow nail syndrome. This will be your diagnosis. Young syndrome, I told you how to diagnose. You're going to have obstructive azoospermia, but you will not have situs inversus. But whereas this patient will have primary ciliary dyskinesia, very commonly they will have situs inversus because they tend to have cartilaginous syndrome. And yellow nail syndrome, they will have typically the pleural effusions and yellow nails. That itself will give you the diagnosis most of the time. If none of these features are there, see for the tracheomegaly. Whether tracheomegaly is given or trachea diameter is more than 3 centimeter or not. If yes, answer will be Mounier-Kuhn syndrome. If no means, your answer will be William Campbell syndrome. William Campbell syndrome. So these are some of the important approaches that you have to know for diagnosing a bronchiectasis in exam. At the same time, one more thing I'll also like to tell. Typically, if they give a right middle lobe and lingula involvement in bronchiectasis, plus if you're dealing with an elderly female, very, very stereotypical case in exam, diagnose MAC complex. This is a Mycobacterium avium complex. Because this disease, I told you already, it is going to be called as Lady Windermere syndrome. Clear? So this is a very simple approach of bronchiectasis to exams for the diagnosis part. There are a lot of other things also, but I feel this is the one that they're going to ask very commonly. And bronchiectasis, in the long run, it can lead to amyloidosis also. That's also a very classic question in exam. So keep all this in mind. And with this, we can wind up with the bronchiectasis and we'll move to the next topic, that is on cystic fibrosis.